We'll try to finish it today. This is our last lecture in CNS. We will take two important topics which are related to the CNS. First one that is related with our PBL case that are called anti-seizure medication or anti-epileptics or anticonvulsants, whatever you want to say. All these different names are used for these drugs. As you have already taken it in your PBL case, Jasmine was suffering from epilepsy, and hope you also discussed with Dr. Ali about the types of seizures that we have: generalized, petit mal, absence, or they have changed it to focal, with conscious, without conscious, these different classifications. Our focus that will be on the two important drugs. There are very many. You see a very long list. We have first generation, then we have second generation, and then we have the third generation. The drugs that you will see in your clinics, because unfortunately epilepsy is not uncommon. You will find patients, especially female patients, suffering from epilepsy. Mostly they will use first generation and second generation anti-epileptic seizures. Why I put this graph? Just to show you that how big number of anti-epileptic drugs we have. First thing. Secondly, all these drugs they can be used for some other problems also, not only for epilepsy. The first one in this group that is called phenytoin, and that is one of the oldest anti-epileptic drug. The mechanism of action is that it prolongs the sodium channel inactivation. As sodium channels play important role in the action potential, and action potential that starts the process of the seizures in the brain, so it will delay the sodium channels, it will prolong the inactivation. So we can use it for partial as well as for tonic-clonic. I hope you also know tonic-clonic. Tonus and clonus means contraction and relaxation, are what we say the convulsions that are related with generalized seizures. But if the patient is suffering from absence or absent seizures, we don't use phenytoin. It is not very effective. Pharmacokinetics, biphasic, first order, then zero order, that is not related with you. That is for those who are in pharmacy or in a medical school. That means that the drug absorption is not consistent. That means sometimes it goes up in the serum and sometimes it goes down. So that is related with it. What is important for us? IVIM, phosphatidylcholine. The problem started because you see there is a condition that is called status epilepticus. Status epilepticus means emergency condition, where the seizures last for more than 5 minutes, up to 30 minutes. Then we need to give the patient injectables. Injection is given. And phenytoin injection, especially intramuscular, there were always problems. So to overcome these problems, we brought a new drug that is called fosphenytoin. It is the younger brother, but it can be used both intramuscular as well as intravenous. Remember, orally still we use phenytoin. Orally still we use phenytoin, but if we need to use intramuscular, or what we say injectables, then we use sometimes intramuscular as well as IV phosphatidylcholine. One thing that you will see quite common with all these anti-epileptic drugs, and this is one of the reasons that we discuss it in dentistry, that are the drug interactions. Because these drugs, they are metabolized in the liver by the enzyme system that is called CYP450 enzyme system. So it induces the CYP enzyme system, the same system that induces barbiturates and carbamazepine. These are two other drugs which are used in the epilepsy. So highly plasma protein bound, as we discussed in general pharmacology, that if the drug is more plasma protein bound, less free drug will be available. So it will take more time to go out from the body, and the onset of action will also be slow. Decrease the effectiveness of PO contraceptives. PO contraceptive means para-oral contraceptives. Contraceptives are the drugs which are used to prevent pregnancy. So sometimes the patient, as we discussed previously, that most of these anti-epileptic drugs, they are teratogenic. We cannot use it during pregnancy except few like lamotrigine. Why? Because they can damage the fetus. So that is another important point, that it can also reduce the effectiveness of oral contraceptives. We need to increase the dose. For example, if the dose is 100 milligram, in case if the female is using oral contraceptives, then we will increase the dose maybe to 150 or 200 milligram. Why? Because if we give the same dose, the oral contraceptive will be inactivated and it will not be effective. Therapeutic levels, monitor blood levels. This is also important. What I told, that because it follows biphasic kinetics, so the serum concentration goes up and down. So for this reason, we need to monitor the serum or blood levels of the phenytoin. As you know that mostly epilepsy is lifetime problem. The patients need to use these drugs for lifetime. So you need to check the serum level or blood level of these drugs at least once in 6 months, once in a year, in ideal situation. Side effects, acute toxicity and chronic toxicity. Acute toxicity means that starts within 1 week, and the patient will come back to you and will be complaining that, doctor, I have these problems. One is called nystagmus, second one is called diplopia, and third one is called ataxia. Nystagmus means that, involuntary blinking of the eyes. The second one is diplopia. The patient will tell you that things look two to me. Dip means two. Diplopia. And the third one is ataxia. The patient tells you that my balance is not good. So these three are the acute side effects. The chronic toxicity, one is directly related to your clinics, that is gingival hyperplasia. If you remember, we discussed in cardiovascular nifedipine gingival overgrowth. Overgrowth and hyperplasia is same, you know, from pathology. It can also cause gingival hyperplasia, especially when we use it for longer duration. And we know we use it for longer duration. Why? Because epilepsy is lifetime problem. So that is another. Sometimes it is so severe that we not only stop the medication, phenytoin, but also the dentist need to remove the overgrown gingiva from the teeth. And another one that is called hirsutism. Hirsutism, again I told that because it is mostly the female's problem, so there will be excessive overgrowth of the hair, especially on the face. And you know, for overgrowth of the facial hair for the females, that is cosmetically not good. Gynecologically also not good, because it is directly related with the reproductive system, but more important, gynecologically as well as cosmetically not good. Vitamin D and vitamin K abnormality, it can also it can cause the deficiency of vitamin K and vitamin D, so the patient need to give supplementation with these two vitamins. This is phenytoin. This one is valproic acid. Please write in bracket broad spectrum. Sorry, I forgot to write broad spectrum.
In what, doctor?
valproic acid, broad spectrum. Normally, we use the term broad spectrum for
multiple uses.
antibiotics.
Antibiotics.
Antibiotics. Normally, we use the term broad spectrum for antibiotics. This is also broad spectrum, but it is not antibiotic. It is called anti-seizure medication or anti-epileptic or anticonvulsant. Why we say that this is broad spectrum, you will see. First one, the mechanism of action. Even from the mechanism of action, we can understand that why it is broad spectrum. It acts by more than one mechanism. The first mechanism, it is same like phenytoin, that it will block or it will delay the sodium channels, as well as it will do one more thing, T-type calcium, that plays important role in the contraction. So this is the first mechanism, that it will inhibit the sodium channels and T-type calcium. Second one, it will inhibit GABA T, as you are discussing with Dr. Fatwi. GABA. GABA stands for?
Glutamate
Yeah.
synthase.
لا.
GABA. Itself abbreviation for gamma amino butyric acid. It is inhibitory neurotransmitter. It is inhibitory neurotransmitter, and it is one of the reason when it is released or stimulated in our brain, we get sleep. Okay, so there is enzyme that cause a decarboxylation, or what we say that can cause degradation of the GABA, because the GABA need to be destroyed, because if it goes up and up, then we will sleep the whole day. But naturally what happens that it goes up, and then by the enzyme GABA transaminase, it starts to degrade. But sometimes you know that we need that it should be not degraded for longer duration, like in case of epileptic patients. So it acts by these three important mechanisms. In first instance, there is inhibition, sodium, calcium, and GABA T or GABA transaminase. One another mechanism there where it will help us, that is the stimulation of GAD. GAD stands for glutamate, that is acetic decarboxylase. This is the enzyme that is required for the synthesis, a conversion of glutamate into the GABA. So this is another. Here it will also increase the GABA. So by four mechanisms, it will help the epileptic patient to reduce the seizures by four mechanisms. Now, where do we use? We use it in all types of seizures, whether it is tonic-clonic, whether it is grand mal, whether it is myoclonus, whether it is absence. So for this reason, we say this is broad spectrum anti-epileptic. If you get question on your exam, which of the following is the broad spectrum? So the answer should be valproic acid. Okay. There are two other uses, and I put it for a reason why, because sometimes you will find patients in your clinic and they will show that we use this drug valproic acid. Naturally, what comes to your mind, because the patient is using valproic acid, so he or she might be suffering from epilepsy. But there is possibility that the patient is not suffering from epilepsy. Other two conditions, although they are also related with CNS, psychiatric conditions, one is mood stabilizer, and the other one, that is migraine. Migraine, you know, that is the headache. So sometimes the patient will tell you, I use this drug, so don't jump or conclude that the patient is suffering from epilepsy. The patient might be suffering from bipolar disorder, the patient may be suffering from schizophrenia, or the patient may be suffering from migraine. So that are also the uses. Valproic acid and ethosuximide. Patient with absence turning into tonic-clonic. This is the only condition, although we are not going into details. Absence seizure, the drug of choice is ethosuximide. In case of absence seizures, the drug of choice is ethosuximide. But if the absence seizures are turning into tonic-clonic, like if you recall the PBL case, in the PBL case, what is happening? That the patient stares, that is called absence seizures, but then starts tonic-clonic seizures. If this is the situation, then we will use valproic acid. If it is only absence seizure, then it is ethosuximide. Okay? Again, monitor blood levels. You know, this is done in ideal situation like in United States or in European countries where the patient, now things are getting better here also, but still it is very difficult that you ask the patient come every 6 months, check your valproic acid, who cares? But still, we do where the seizures are not controlled. Sometimes you will see the patient, especially when you will work in Noor Hospital, you will find patients in psychiatric or in neurology, the doctor will tell you that valproic acid is not working, and the patient will be using 2 or 3 or 4 anti-epileptic medications like in diabetes or in cardiovascular system. There we need to check the blood levels of the valproic acid, whether we achieve the serum level that can cause the seizure inhibition or not. Pharmacokinetics, metabolized in the liver, 90% protein bound. Again, like phenytoin, the plasma protein binding is too much, but here it doesn't induce the metabolism of the CYP4. It prevents the metabolism of the drugs like phenytoin, carbamazepine, and phenobarbital. So what happens that it will increase the level of these drugs if they are given together. The take-home message is that we need to decrease the dose if we use valproic acid together with phenobarbital, with phenytoin, or with carbamazepine. Why? Because it inhibits the metabolism of these drugs. Side effects. Side effects, first one is NV. NV stands for?
Nausea, vomiting.
Nausea and vomiting. Second one is weight gain, GI upset, and sedation. Why it causes sedation? Because it stimulates the or increases the GABA. So any drug that will stimulate or increase the GABA, it will cause sleep. Hepatotoxicity, although it is rare, especially patient with the history of polypharmacy for years, if the patient is using the drug and using other drugs. What I told that sometimes you will see the patient will be taking 4 different drugs for the epilepsy. In that case, there is possibility for the epilepsy. Now we come to the important side effect during pregnancy. If you remember, I told to you in the PBL case, we are Muslims, we believe in Islam. Islam gives us the system of marriage. But when you will travel to America, 70% pregnancies are unplanned. You understand what do we mean by unplanned? Illegal. So if the patient is female, there you will find they don't use valproic acid from 12 to 50 years. Why? Because who knows when the female will get pregnant. So for this reason, they avoid valproic acid. Why? Because it can cause the birth defects, spina bifida, cardiovascular, orofacial, that is directly related with you, and digital defects in the fingers. So it is highly teratogenic. There is no way, even if you look at the PBL case, the patient was weaned off of valproic acid for 1 year because they say that the drug continues to stay in the teratogenic concentration for 6 months. So we must be careful while using it in the female patients. Modulates folic acid. So sometimes we need to give folic acid because it can cause folic acid deficiency. So that is the story of the valproic acid. Again, both are important for you, valproic acid as well as phenytoin. While phenytoin, one of the side effect is directly related with your clinics. Similarly, one of the side effect of the valproic acid, orofacial, is directly related to your clinics. Valproic acid is very commonly used for epileptic patients, but with very important contraindication that it should be used carefully in females. Okay, now we come to our last, that is local anesthetics and general anesthetics. In the very beginning, in my very first lecture, if you recall, because it is almost 6 or more than 6 months now, I told there are 3 revolutions in the medical history. Revolutions mean inqilab, that change everything for medicine, and one of them is anesthesia. Why? Because today you can do any procedure, whether it is dental or whether it is general, like we open the skull, we open the heart, open our surgery. You cannot think 100 years back. Why? Because can you open the heart or can you open the skull without anesthesia? Impossible today. So it is one of the medical revolution. If you look interestingly, the mechanism of action of local anesthetics, it is same like that of the epileptic drugs. Why? Because sodium channels, what we say, this is the pain channel. The pain channel is same. So channelopathy is same. What it will do, that it will do it peripherally, not only centrally, that it will block Vg sodium channels. Vg stands for, you discussed, might be in physiology or in biochemistry. Voltage gated sodium channel, that is related with repolarization, depolarization, and hyperpolarization of the cells. Order of blockade, how it will block the sodium channels. First, it will, when it will block, there will be pain, less temperature, then less touch, and then less pressure. So that is the, it will gradually increase in its activity. First pain will go, then temperature will be reduced, then touch, and then pressure. Uses minor surgical procedures, obstetrics, and dentistry. Inshallah, when you will go to 4th year, you will start your clinics. Local anesthetics for you are like candies. There is hardly any procedure where you don't use local anesthetics. Why? Because when you do any procedure, there is pain. And to avoid pain or to reduce pain, we use local anesthetics. So, local anesthetics, they are used in dentistry, they are used for minor surgeries, like sometimes amputation, some other minor surgeries, stitches, these things we use local anesthetics. Similarly, in obstetrics, during delivery, we use the pudendal nerve anesthesia, and that can also cause the pain-free deliveries. Okay, metabolism. What is the metabolism? We have 2 types of the local anesthetics. One are called amides, and the other one are called esters. First came ester, and then came amides. Ester is still very commonly used in ophthalmology, eye, because eye surgeries are also mostly short duration, and they are also available as eye drops. So they instill eye drops and they do surgery. So that is ester. What happened?
Finish.
Finish? Okay. I think got tired, huh? It is automatic.
That doesn't give me عايزين كمان نشوف.
لا البروجيكتور ما ادري يولع ويطفي.
Switch off where is, or it's switch off only from here.
كان بقى مشارك هنا.
No, it's, I think it's nice. Okay, so we have two types. One is called ester and the other one are called amides. Keep in mind, in dentistry, we use amides. In dentistry, we use amides. Sleeping morphine machine. Okay, so the metabolism of the ester, it is hydrolyzed in the blood or it is hydrolyzed in the plasma. It is very important to keep in mind. For this reason, the duration of action is also short. It is hydrolyzed in the blood. And you see short half-life. The other one, amides. Amides, they are hydrolyzed, but they are hydrolyzed in the liver by the enzyme system that is called CYP450 system. Increased toxicity with liver disease. What do we mean by this? If the patient is suffering from hepatitis, if the patient is suffering from liver cirrhosis, then what will happen? It can cause the toxicity. Why? Because the drug is hydrolyzed by the enzyme system that is in the liver. Okay? And for this reason, we use it in relatively smaller dose in younger or in children as well as in elderly. Why? Because there the hepatic or liver system in children, it is not fully mature, and in elderly it is reducing. Okay, redistribution dictates the duration of action. Redistribution means that it goes from the liver to the body, different system, and that increase or decrease the duration of action. That is directly related with the dose of the drug. If you have done any dental procedure in your life, you can understand this. Mostly, the dentist give first injection, wait for some time. You might have seen this, doctor will tell you, okay, wait for 10 minutes. That doesn't mean that he is busy on the social media. He is waiting that the drug should show its effect. Then he will ask, sometimes he will touch the tooth and ask, still you feel pain? Then you say no pain. Then he will start, because temperature, pressure, touch, they will come later. When he will do the procedure, sometimes, and you will see, especially inshallah when you will be in 5th and 6th year in surgery, sometimes you need to repeat the dose. Similarly in endodontic RCT, root canal is long procedure. Ideally, dental procedure should not exceed 40 minutes. How many minutes? 40 minutes. But many times we need to, why? Because this is the duration of action of these amides. If you want to prolong, you need to repeat the dose. When you need to repeat the dose, what we say, redistribution dictates the duration of action. Then, okay, the pain will start to disappear, but it will continue, some of the side effects will continue for longer duration. So that is important. Side effects last. Last means local anesthetic, systemic toxicity. Local anesthetic. The side effects ideally should be local. Ideally should be local. But as I told, because we need to repeat the dose, so the side effects don't remain many times local. Okay, first one, there will be CNS toxicity, CNS activation, CNS depression, and respiratory failure, God forbid. Although this is not very common, but there is possibility, especially when you repeat the dose. It will cause first the CNS activation, then CNS depression, and CNS respiration depression, then the patient will go to but this is very rare. Don't worry, because you will use it. Each and every patient you will use local anesthetic. Cardiovascular toxicity slightly more, but it is not fatal. What it will do? Decreased conduction rate, force of contraction, as we discussed in the cardiology, in the cardiovascular system, that is chronotropic, dermotropic effect. Prolonged AAP, refractory period, action potential period, and then vasodilation. It will cause vasodilation, with one exception: cocaine. Cocaine, initially the first local anesthetic was cocaine, and even today cocaine is the best local anesthetic. Today even cocaine is the best local anesthetic. It fulfills all the criteria of the local anesthetic. What is the problem with cocaine? Addiction. Even now we don't use it. Eye drops. You see eye drops, 1-2 drops. What will happen? It can even cause addiction. Otherwise, it is best option. Why? Because itself it causes vasoconstriction. And vasoconstriction is one of the important thing in dentistry. Why? Because there is always chance for bleeding. So we need the drugs that should cause vasoconstriction to minimize the this side effect. And you will see, for this reason, and you might have discussed with Dr. Ayman in autonomic physiology, we add adrenaline. Why we add adrenaline? This is one of the reasons that it will reduce the bleeding chance. Hypersensitivity, you understand, allergic reactions, they are more common to esters. So normally we use in dentistry the amides. Yes.
This side effect happen if I give a high dose?
No, which one? This last is related with high dose, but this hypersensitivity, that is more common with esters. Even with eye drops it can cause.
Doctor, you said the CNS necessity when we
Rare.
dose. When we repeat dose, we repeat the same amount? Like till
Yeah. We repeat the same amount.
every time?
Yeah. We need to repeat. It is in 0.5 ml, 1 ml, even sometimes less than then, but still it is a big amount. One thing, thank you. Also, thank you. Sometimes what happens that the injection may go into vein, and when it goes into vein instead of the muscles, then what happen again? More amount is going into the blood. That can also cause systemic toxicity, although it is very, very less. The second one, cardiovascular, sometimes you will see the patient will collapse. That is what we say vasovagal, sometimes due to fear. Many people, even due to pain, when you inject, pain is there. So, and for this reason, sometimes the dentist first applies spray to minimize the pain. So, but there is possibility that it goes into the vein, and that can cause the increased dose or toxicity. But still, it is not very common. But you will see, especially in maxillofacial surgery and in endodontic, like nowadays they have introduced single sitting, what we say the root canal treatment. Root canal, if you, any one of you have done, no, none? What is root canal in Arabic? Something very, yeah, jazor. So what they do, that they ask, come today, then after 1 week, and then after 1 week, like this. But now they say, no, we can do it in one sitting, because we have technology, we have x-rays, we see how much deep we can go into the roots. So they cut the nerves and they finish in one. But one sitting or session, it will not be a 40 minutes. It may take 2 hours. So 2 hours with one injection of lidocaine, impossible. So you need to repeat the dose. Why? When you will not repeat the dose, the patient will raise and I feel pain. So for this reason. So there is possibility for the toxicity. But it's not that much. And now we have more safe, instead of lidocaine, you will see different names. Here, how you will know that this is amide or this is ester? You don't have time to Google it or to open the book. So there is something very interesting. Esters, one eye, and amides, two eye. Like you see this bird, it has one eye, and this bird has two eye. So all the esters, they have one eye. Although normally we don't use esters in the dentistry, but sometimes if you don't have amides, or if you go like in war-torn countries, like to Yemen or to Syria, working as social work, Saudis like mashallah. So there you don't find the amides, they are like slightly expensive and you need to use. So how you will know this is ester or this is amide? If it is one eye, like cocaine, one eye, procaine, one eye, benzocaine, one eye. If it is two eye, then it is amide. Lidocaine, two eye, prilocaine, two eye, mepivacaine, two eye, bupivacaine, two eye. So if there are two eyes in the name, in the spelling, so it is amide. If it is one eye, it is ester. Okay. The very commonly used in our clinics, that is the lidocaine. Most commonly used overall and drug of choice for ester. If someone is sensitive or hypersensitivity, like in case even in ophthalmology, normally in ophthalmology we use esters, but if someone is having hypersensitivity, then we will use lidocaine. Intermediate action, the action may be from 30 to 45 minutes. That is the effective duration where you can do the procedure. And then the side effect, drowsiness. Second one is prilocaine, intermediate acting. Some reports of the toxicity are there with the prilocaine. So sometimes we use it, sometimes we say no because there is more possibility. For the third one, even that is, if you go downstairs, mepivacaine. Mepivacaine is nowadays we use because it is better option, intermediate action, but the side effect of the drowsiness is less. It is there. All the local anesthetics, especially amides, they cause drowsiness, but lidocaine causes slightly more. Okay, so we use, it is for obstetrics. Obstetrics means during child or baby delivery. In France, they encourage the mothers normal delivery. But you know, normal delivery is always painful. Giving birth to a child without anesthesia, without cesarean, through vaginal, normal delivery means vaginal delivery, it is painful. So what they do, they give the injection in the spinal region in the back, so the female doesn't feel pain. But the gynecologist or the obstetrician must be there sometimes because maybe some complication develop. Otherwise, it is pain-free delivery. Side effects, especially in neonates. Why? Because when we use it in the obstetrician purpose, then it can cause neurobehavioral effects. The child, neurobehavioral effect means the child may be crying for longer duration, may not be sleeping after this procedure when it is born by this procedure. We use it also in dentistry, quite good. Bupivacaine. Bupivacaine is used for two purposes. Post-op analgesia. Post-op analgesia means
After taking analgesics.
after surgery. Interesting thing. All the local anesthetics, they are also analgesics. They are also analgesics. They are, because when we do procedure in the dentistry, we don't want that the patient should sleep. What we want, that the patient should not feel pain. The patient must be pain-free and conscious. Even sometimes you speak to the patient is speaking to you during the procedure. Why? Because he is conscious. Anesthesia itself means that the patient should be unconscious. But in local anesthetic, the main purpose or the target that the patient should not feel pain. So sometimes in general surgery, if there is severe pain, especially like in cancer patients or in burn patients or in orthopedic surgeries, God forbid road accidents, the pains are very severe, then we use even bupivacaine for this purpose. And also we use it in obstetrics. Normally bupivacaine we don't use it in dentistry except in maxillofacial. If the procedure is long, then we can use bupivacaine. The duration of action is very prolonged, 24 hours. Cardiac toxicity is there. So we must be careful while using it in cardiac problem patients. Okay, vasoconstrictor, that you will see many times in your clinics. If the patient is young, not suffering from cardiovascular problem, we use it in combination with adrenaline or epinephrine. They are same. Local blocks most cause vasodilation except cocaine. What I told, all the local anesthetics, they cause the vasodilation. But cocaine and also some say prilocaine also cause vasoconstriction. But cocaine for sure causes vasoconstriction. But as we know, we cannot use cocaine in many patients. So and increase the systemic absorption. EPI or epinephrine decreases the rate of absorption, and that is required because if the rate of absorption is increased, there is more chance for the systemic toxicity, and it will also decrease the toxicity. Side effects. We have side effects when we use adrenaline or epinephrine in combination with amides like lidocaine, restlessness, increased heart rate, palpitation. These are all the cardiovascular or autonomic side effects. Chest pain, regional hypoxia, and sometimes tissue damage. That can happen when we use in repeated dose. Like as I told, sometimes you need to repeat the dose, then it can cause these side effects. Mostly it is quite safe. We use it very commonly in our clinics in this combination. Now, general anesthesia. Only those who will be in maxillofacial, they may need to use general anesthesia. Otherwise, general anesthesia is used by general surgeons.
So we can use it in the pediatric, in the pedo.
Yeah, but in pedo, again, not good choice. For any dental procedure, going for general anesthesia will be the news in Saudi Gazette or Arab News that a pedo dentist used general anesthesia. Why? Because the side effects are always there, and most of the dental problems can be managed or can be even postponed, unless like in accidents you don't have any other option, then you need to repair it immediately. Otherwise, if it is general dental problem, we can postpone. They are quite good, they are quite safe, but still they are general anesthetics. General anesthetics always have some side effects. They are never without side effects. We have 3 phases. One we say induction, the second one is maintenance, and third one is the recovery. So, and that what will happen, there will be unconscious. The patient will not feel the surroundings. What we say, the deep sleep or anesthesia. Anesthesia means that the patient doesn't know anything about the surroundings, what is going. And amnesia is also important. The patient must forget what happened to him. But because if he knows that my abdomen is open or the skull is open, so it will come in his dreams for many months. But what happens, he cannot recall what happened to him. When he gets up or recovers from the general anesthesia, he just finds pain. Why? Because stitches are there and he feels only pain. So reversible drug-induced loss of consciousness, what I told, characterized by hypnosis. Hypnosis means sleep. Amnesia means forget, he will not recall what happened to him. And lack of response to noxious stimuli. As you discussed with Dr. Aman, noxious stimuli, even you cut the finger, the patient doesn't feel. That is the maximum. Amputation. You have seen many times amputation with diabetic patients. We do it and the patient doesn't feel pain. After that, there might be pain, but at that time there is no pain. So that is part of it. Two main medication routes. Some of them they are given injectable, some of them they are given by inhalation. So inhalational gases, sevoflurane and isoflurane. Mostly, as Faisal said, in children we use inhalation. They are quite safe. Sevoflurane or isoflurane. Mostly we use sevoflurane. Intravenous, we have thiopentol, propofol, and ketamine. In bracket, you can write with ketamine. It is given intramuscular also. Ketamine can be given intramuscular. Propofol is called, we use it for daytime surgery. Daytime surgery means when we discharge the patient on the same day. So we can sometimes use it for this. Propofol is also used to give you sleep. You know Michael Jackson. Michael Jackson died because of propofol. Why? Because he used to receive every day propofol injection to get sleep. Look, he was so rich and he used to use propofol for sleep. Subhanallah. So everything is not money. So propofol is also good. Thiopentol, short duration. So that is the story of the. We can speak many things about this, but because we don't have time, and you may discuss later on in 4th, 5th year in surgery also. Sevoflurane, keep in mind, and propofol, keep in mind, and ketamine, because ketamine with one good thing that we can use it intramuscular. Propofol and thiopentol, they are used in the intravenous route. Okay, let's play math. You will see they are available. Sorry, what happened? Okay, they are available as percentage. They are available as percentage. Now, lidocaine 2% are in ratio. Lidocaine 1 over 10,000 or 100,000 and 200,000 like this. Plain or sometimes plain means when it is alone. When we say 1 over 100 times or 200 times or 10 times, so that is when it is given with adrenaline. When it is given with adrenaline. Whenever it is in ratio, the ratio is for the adrenaline. Now, how you will calculate? What do we mean by 2%? I tell you very easy trick that will help you all the time. Just add only 0. Just only add 0 or multiply by 10, because sometimes there will be point, then it will make problem. Like if we have 2%, 2% means how many milligram? 2 times 10 means 20 milligram. 20 milligram in 1 mil. 20 milligram in 1 milliliter. 20 milligram in 1 milliliter. Similarly, 4% means
40 kilogram.
40 milligram 1 mil. For example, if it is 0.4%, then how much it will be? 4 milligram. Very good. For example, if it is 0.1%, 1 milligram. If, for example, if it is 0.5, 5 milligram. That's it. There is a formula we can calculate, because 2% means that it is taken in gram and then we convert it into 2 gram into 2000 gram, then we divide it by 100 mil. So that is a formula. But just to get it easy, just multiply by 10 when it is alone. When it is in ratio, again it is very easy. 1 stands for 1 gram. 1 stands for 1 gram. So 1 gram means how many milligram?
10 milligram.
10,000. 1,000 milligram. Not 10,000. 1,000. 1 gram equals to 1,000 milligram. So 1,000 divided by 100,000. How much it will be? Open your calculator. Yeah, that's no. Mark. And the leader is sleeping. Mark, today I will make him.
He actually sent me, he's having trouble.
Trouble, yeah, he was going. Okay, so 1 means how many milligram? 1,000 milligram. So 1,000 divided by 100,000.
0.01.
0.01. Okay, so 0.01. So if we want to convert it into microgram, so what we will do? Multiply by
10 to the power of minus 6.
minus 3. Microgram. Already they are in milligram. Yeah. So how much it will be? Multiply by 1,000.
0.01.
Multiply by
1,000?
yes.
10.
10 microgram. So you can understand how small dose of adrenaline is given. 10 microgram is nothing, but still this 10 microgram can cause sometimes side effects, especially tachycardia. So be careful while using it in patients who are already suffering from cardiovascular disease. So this is our story of the anti-seizure medication and local anesthetics and general anesthetics. Again, keep in mind in dentistry we use amides. If you can't remember anything, 2 eyes, amides, injectables, and mostly we use lidocaine, or nowadays we also use mepivacaine. So that you should keep in mind. If you get question on your exam, how to calculate, hope you can easily calculate, because if you see percent, just multiply by 10. If you see the ratio, make 1,000 and then divide. That's it. Okay? Any question? Thank you. See you inshallah. If you need